Hi, this is Dr. Moreno. Welcome to the first pre-lecture recording from the psych module. The focus of this lecture will be on insomnia. The objectives for the overall insomnia lecture are listed below, and there are 6 of them. For the purposes of this pre-recording, we'll focus on just the first 3. So by the end of the lecture, you'll be able to describe a normal sleep cycle, you'll be able to identify possible etiologies of insomnia, and you'll be able to characterize the different types of insomnia. So let's get into some background. We have a few sleep definitions before we dive right in. I'd like to explain what sleep architecture is. So the definition of that is the basic structural organization of sleep. So this takes into account both REM and non-REM sleep, as well as the different stages of sleep. So when we say sleep architecture, we're referring to the quality of sleep that occurs within a person's sleep cycle. Non-REM sleep, or NREM sleep, is non-rapid eye movement sleep. So this is divided into stages 1 through 4, where each stage is associated with a characteristic brain activity. Stage 1 is the lightest stage of sleep, so this is the stage where you're most close to being awake, and stage 4 is the deepest stage of sleep, where you're having very slow brainwave activity and you're in a very deep sleep. REM sleep is rapid eye movement sleep, and this is the stage of sleep that's most often associated with dreaming. So to divide out the different stages of non-REM sleep, we have stage 1, and this is the part where a person transitions between being awake and asleep. It typically is where sleep begins, and it takes a period of about 15 to 30 minutes from the time that somebody may lay down to fall asleep and actually fall asleep. Within stage 1, someone will start to have decreased muscle tone, they'll have decreased eye movements as well as decreased brain activity. And however, within stage 1, only a small stimulus is required to fully wake somebody up from this light stage of sleep. Moving from stage 1 into stage 2 sleep makes up about half of the total sleep time. In stage 2, you actually have complete cessation of eye movement and muscle activity. And within stage 2, as it kind of makes sense, there's a larger stimulus required to wake somebody up than would be required to wake somebody up from stage 1 sleep. In stage 3, we have sleep that is similar to the next stage, stage 4. However, within stage 3, you have less what's called delta wave or slow wave sleep. And that's those delta waves are visible within an EEG, which I'll actually show, I think, in the next slide. And that really just shows you that the brain has very slow wave activity happening, and it indicates a very deep sleep. Stage 3 makes up only about 3 to 8% of total sleep. And this is where deep and restorative sleep begins. You can go then from stage 3 into stage 4, which, like I had just mentioned, is similar to stage 3, but stage 4 you'll have much more delta wave, or that slow wave sleep. And stage 4 makes up about 10 to 15% of sleep. Within stage 4 sleep is where the arousal threshold is highest, and so it will take the most stimulus or the greatest stimulus to wake somebody up from stage 4 sleep. And then, as I've noted in this blue box down here, stages 3 and 4 are the most restorative sleep. So the more time you're able to get within stages 3 and 4 sleep, the more probably energized or well-rested you'll feel upon awakening. So here we have a sleep EEG, and all of these are non-REM sleep. So none of these is showing the EEG patterns from somebody who is experiencing REM sleep at this time. But this is just to show you, and you don't need to memorize any of this. This is really just for for people who might be curious about what I was just talking about on the last slide. So stage 1 sleep, you see you have very rapid wave movement, and it's got, you have short amplitudes, and it's quite rapid. And then as you move into stage 2, you see that the waves start to slow down a bit, and that's indicated by these kind of bigger amplitudes growing. And then you'll actually even, this one spike that's pointed out in this arrow is a delta wave. So even within stage 2, you start to have just a little bit of that slow wave sleep. And then as you move further into stage 3, you see more slow waves coming in. And this section right here that I'm circling is a bout of delta wave sleep, or that slow wave sleep. And then you see stage 4 is made up almost completely of delta wave sleep. So that was REM sleep. So now moving in, or I'm sorry, that was non-REM sleep. So moving into REM sleep, we have so rapid eye movement sleep. This makes up about a quarter of total sleep time, and this is when dreams occur. You actually have desynchronized brainwave activity. So where in non-REM sleep you had much more methodical and consistent wave patterns, within REM sleep those wave patterns are not as consistent. You have generalized muscle atonia, or also known as paralysis. So when somebody is in REM sleep, their muscles, their body parts should not be moving because they shouldn't be able to move. You'll have bursts of bilateral rapid eye movement. So this is when you look at somebody and you see that they're dreaming, you can see their eyes moving underneath their eyelids. And then you'll also have fluctuations in respiratory and cardiac rate. So there are quite a few physiologic differences between what's happening in the body between somebody in non-REM sleep and in somebody in REM sleep. For the most part, most of what happens in non-REM sleep is almost the opposite of what happens in REM sleep, and you can kind of keep that as just a general concept to remember. However, there are a couple that are similar. So airway resistance, if we were to compare it to wakefulness, so not comparing non-REM to REM, but comparing both of those to wakefulness, you have increased airway resistance both in non-REM and in REM sleep. And then otherwise, most of the comparisons, like I said, are pretty much exactly the opposite between non-REM and REM sleep. So just for example, where you'll see that brain activity is decreased from wakefulness in REM sleep, in non-REM sleep, brain activity is decreased. In REM sleep, you actually see an increase in brain activity, specifically in motor and sensory areas. And then, like we've already stated on previous slide, muscle tone in non-REM sleep might be similar to wakefulness. It might be a little bit decreased, but relatively similar, whereas in REM sleep you have paralysis, and so you have absolutely no muscle tone at all. So for sleep cycle, or like I said, sleep architecture, this is just to highlight that sleep needs vary between individual people, so individual patients or people that you might meet, as well as across different age groups. In general, most adults aged 18 and older require 6 to 9 hours of sleep per night. And in general, it should take only about 15 to 30 minutes to fall asleep once someone has decided to go to sleep. Most individuals will experience all 5 stages of sleep, and it should be in succession. So it should go, somebody is awake, and then they go into stage 1, and then that progresses 2, 3, 4, and then into REM sleep. That full succession of those 5 stages is one sleep cycle, and typically people will experience about 5 complete cycles of sleep per night. And what happens is that they'll go, when they go from stage 1 to 2, 3, 4, and REM, once they have completed their REM stage of sleep, they'll go back into stage 1, and then it starts the cycle over again. Each cycle lasts between 90 and 110 minutes. So there are sleep changes that happen depending on someone's point in that they are at in life. So children typically need more sleep than adults. Adolescents, we may see that they have a delayed sleep phase syndrome. So what that means is that they're more likely to fall asleep later and then wake up later. So this is where some of that controversy comes in about having high school students going to school so much earlier than their younger counterparts like elementary school students, when in fact what we know is that high school students actually may perform better in school if they were able to sleep in later, fall asleep later, because they're going to get more quality sleep in those times. And when you have better quality sleep, you typically have better performance. As far as the elderly goes, they have quite a few different changes in their sleep. So their sleep in general, in a 24-hour period, might not change in the total number of hours of sleep that they get. However, that sleep may be spread throughout the day. And what that means is they tend to take a lot of naps. So Grandma Jane may have a 2-hour nap in the morning and a 2-hour nap in the afternoon, and then she may only sleep 4 hours at night. The elderly also are more likely to have what's called advanced sleep phase syndrome. So this is in contrast to the adolescent delayed sleep phase syndrome. So in the elderly, they're more likely to fall asleep quite a bit earlier, but also wake up quite a bit earlier. The elderly are also more likely to report frequent awakenings throughout the night. It's easier for them to wake up. And this is really related to them getting much less of that deep restorative sleep, so much less of the stages 3 and 4 sleep. And this is particularly true in people over the age of 70. So what's insomnia? So we just learned all about sleep and the stages of sleep. But when we're talking about insomnia, what we're talking about for the most part is a patient-reported problem. So this is not something that we can really identify with a series of tests or labs or anything like that. This is something that patients report they're having issues with their sleep. I like to refer to insomnia as something less of a brain disease most of the time. Sometimes it's definitely a brain disease that is causing the insomnia. However, when I talk a lot about psychiatric illnesses, and you'll learn about other neurologic disorders, we kind of come to accept these as a brain disease with some education. And with insomnia, very often the reason for difficulty sleeping is more related to situational problems, medical illnesses, substances at play. And so it's less of alterations in what's going on in the brain and the neurocircuitry. So people might report difficulty falling asleep, they might report difficulty maintaining sleep, or they might just say that they're having non-restorative sleep. And what that means is that they may say, yes, doc, I'm sleeping 8 hours a night, but all throughout the rest of the 16 hours a day that I'm awake, I'm exhausted, and it's every single day this is happening. So that's what's called non-restorative sleep. Insomnia is one of the most common complaints in primary care. Patients report it all the time, and you'll see that when I get into some of the epidemiology of it. Insomnia is not defined by a specific sleep amount, so we don't have any criteria that says if you sleep less than 5 hours a night, then you have insomnia. There's nothing like that. It's all patient reported, and it's the patient's perception of how they feel they're getting, whether or not they're getting enough sleep and whether or not they feel restored throughout the day. There are objective measures like polysomnograms and several different like electroencephalograms, EOGs, EMGs. However, these are not sensitive in the diagnosis of insomnia. There is one objective measure that we do use. However, it's more to diagnose, instead of insomnia, it's to diagnose sleep apnea. And so while some people may report, and you'll learn about this a bit more, but while some people may report non-restorative sleep, one of the biggest things that comes to mind for us when we hear non-restorative sleep is, ooh, do they have sleep apnea? Because if you have sleep apnea, while you may think you're getting all of that sleep, you're having so many periods throughout the night of little mini awakenings because your throat has closed or your air passages have closed so you can't breathe, that you wake up a little bit, but you're in a state of subconsciousness so you don't even realize that you fully wake up. So what happens is that people, like this might be one of those times where people will get 8 hours of sleep and wake up and feel completely unrestored. So in that case, we can do objective sleep studies to diagnose sleep apnea and determine whether or not that is the cause of the person's report of non-restorative sleep. And then, as I had kind of previously mentioned before, typically insomnia involves a person's altered perception of their sleep. So lots of times people tend to think they're sleeping quite a bit less than they are sleeping. And it's really just all about how they feel their sleep is restoring them and making them feel rested. Well, so if it's not a brain disease, why do we need to treat it? Well, the fact of the matter is that insomnia, like we just learned, is one of the most common commonly reported complaints in primary care. And insomnia comes along with an assortment of complications. So when people aren't getting enough sleep, they're too distracted, they have poor attention spans, they have a lack of motivation because they're so tired that they just maybe want to lay in bed or lay on the couch all day. They may become irritable or have a low frustration tolerance. And then they'll also start to develop, or maybe in the process of developing, a variety of psychiatric illnesses like depression and anxiety and an assortment of others. So for the epidemiology, like I said, insomnia is incredibly common. Over half of individuals, just in general, will complain of insomnia at some point in their lifetime. And then about a quarter to just over a third of the population will report an occasional sleep disturbance. About 80% of elderly patients have sleep complaints. So like I said, this is incredibly common. And many patients with insomnia have comorbid psychiatric disorders, and that's actually why I put this lecture first, because insomnia is such a common thread throughout all of the psychiatric disorders that it's important to have a decent understanding of what's going on with it and how it can play a role or complicate other psychiatric disorders. So where does it come from? How does insomnia even start if it's not a brain disease? Well, sometimes it is a brain disease. It's just not that common for it to be. And when it is, that's called primary insomnia. So we don't really have a good understanding of what that true cause is. It might be related to an abnormality of the person's inherent sleep-wake cycle, or their circadian rhythm. So maybe their internal clock is off or on haywire or just out of whack for some reason. That's primary insomnia. And so there's no other cause, it's just the fact that the person has trouble sleeping. Whereas secondary insomnia is insomnia due to, or sleep trouble due to, a variety of other causes. And so these causes can be situational, medical, psychiatric, or substance induced. So just to paint a couple examples, situational would be like work or financial stress. The person's worrying a lot about things. Medical is almost any medical illness can cause insomnia or medical conditions. Psychiatric, again, almost any psychiatric condition can also cause insomnia, like mood disorders, anxiety, trauma histories. And then substances can also cause insomnia. You can have anticonvulsants, steroids, as well as stimulants or things like cocaine or amphetamine salts and those kinds of things that will cause somebody to be awake. And then the alternative of that is that you can actually have substance withdrawal induced insomnia. So what that means, and what is very commonly seen, is that in people who have a physical or physiological dependence on things like alcohol or opioids or benzodiazepines, basically anything that makes you sleepy, when you remove that substance, it causes the person to feel insomnia through their withdrawal or experience insomnia. So what is going on? So while we may not have a clear understanding of where it comes from, we have some idea of some of the neurotransmitters that are at play. And the NT stands for neurotransmitters. So we have sleep-promoting substances in the brain, and we have wake-promoting substances in the brain. Of the sleep-promoting substances, we have GABA, adenosine, and melatonin. So GABA is our primary inhibitory neurotransmitter. So what that means is when we say that it inhibits things, it slows everything down. GABA stands for gamma aminobutyric acid. And so it is, as the primary inhibitory neurotransmitter, GABA will slow nerve firing so that in general just everything gets slowed down, and that just tends to cause sleepiness. Adenosine inhibits wake-promoting neurons. Melatonin induces sleepiness. Melatonin's kind of interesting because it actually responds to the environment, and so if it's bright and light outside, our melatonin is suppressed, and then if it gets dark outside, that signifies that it's time for our body to start slowing down and to start thinking about sleep, and our melatonin increases, like our melatonin levels in our body actually increase. And this gets kind of interesting because when we think about other things that might make our body think we're in a situation of bright light, like the blue light from our phones, that actually causes our melatonin to be suppressed. So a lot of times people will report insomnia when in fact, if they just put their phone down an hour before bedtime and don't pick it back up, they might that insomnia might actually go away completely. Then we have wake promoting substances. So we have norepinephrine, or NE. This is also known as noradrenaline or adrenaline. Norepinephrine has decreased activity during sleep that's associated with a loss of muscle tone. You have acetylcholine, which promotes arousal and promotes REM sleep, because REM is actually more of like an active type of state that our brain is in during sleep. We have histamine, which promotes and maintains wakefulness. So we know that antihistamines like diphenhydramine or Benadryl are things that make us sleepy. So histamine actually makes us awake. 5-HT is the abbreviation for serotonin, which is a common neurotransmitter we'll talk about quite a bit throughout the next five or six lectures. High levels of serotonin increase wakefulness. Dopamine increases alertness, and orexin is a neurotransmitter that also increases wakefulness. So basically, dysfunction in any of these neurotransmitters can lead to insomnia. So how do we characterize insomnia? Well, we have a few different types. So there's initial insomnia, and that's when people report difficulty falling asleep. The increased or an increased time to sleep onset that is longer than 30 minutes. Time to sleep onset is defined as sleep latency. So when somebody, you may hear experts in the field say extended sleep latency, and that means that they have extended time to falling asleep. It's taking them too long to fall asleep. Middle insomnia is difficulty maintaining sleep as well as frequent awakenings during the night. So they may wake up too many times and they may or may not have difficulty falling back asleep. Terminal insomnia is an early morning awakening. Somebody should be reporting a total sleep time of less than 6 hours. So this is somebody who goes to bed at 10 o'clock at night, wakes up at 3 o'clock in the morning, and cannot fall back asleep. Incidentally, this happens to be quite common in depression, although the cause of that isn't exactly well known. And then the final type of insomnia is excessive daytime sleepiness and non-restorative sleep. So this is when you have the people saying that they're sleeping 8 hours a night, but they're not getting any sleep, or they're not feeling rested at all. And in general, this results in fatigue throughout the day. So the DSM-5 criteria for insomnia disorder, and we'll go through DSM-5 criteria for each of the mental illnesses that we're going to talk about throughout the psych module. Insomnia disorder is also known as primary insomnia. So this is the one that is not due to a variety of other causes. Patients will report an unsatisfying sleep quality or quantity related to sleep initiation, sleep maintenance, or early morning awakenings. They'll say that it's happening at least 3 nights a week and it's been present for at least 3 months. They'll say that the disturbance is present even when they have ample sleep opportunity. And what that means is maybe during, so this is saying that every day of the week, no matter what, they have trouble sleeping or they're having some sort of difficulty or unsatisfying quality or quantity of sleep. This can happen, sometimes people will say that they're having difficulty sleeping Monday through Friday, but then Saturday and Sunday they have no trouble sleeping and everything's fine. And what that's actually more of an indicator of is the fact that maybe they're working Monday through Friday and they go to work so early that their body is just not very comfortable with that sleep phase or sleep phase that's required of them by work. And maybe there's somebody with more of that delayed sleep phase syndrome where their body prefers that they stay up later and they sleep in later. So one of the most important things to remember with any psychiatric illness is that the disorder causes social and occupational dysfunction. Without social and occupational dysfunction, we tend to say that it's not a disorder. So somebody really has to have trouble with their relationships at home, with their friendships, with the ability to go to school and do well in school, with the ability to go to work or do well at work, just all sorts of things that would be involved in their social and occupational functioning. Those things should be impacted by this disorder. And then the other qualifier that's present in all of the DSM-5 criteria is that this disorder is not associated with another medical or psychiatric diagnosis, it's not associated with another sleep-wake disorder, and it's not induced by a substance. The DSM-5 then specifies these insomnia disorders further by saying, is it episodic, which means it's been lasting about 1 to 3 months. It's persistent, so it's been lasting for at least 3 months, or it's recurrent in that the person has at least 2 episodes every year. So that concludes the pre-lecture material for the first lecture on January 12th. I look forward to seeing you all that day.